Okay, so the first one is Norbert van Dijk.
Yes.
Change our sheet. There at the end, on the right.
Dr. Hoekstra.
Hoekstra. She's
Hoekstra.
got a PhD.
Hoekstra. Okay, that's right. Yes. Professor, thank you.
He's doctor, I think. I would guess doctor. He's doctor.
It's a bit
Good morning. Good morning. Good morning. Welcome to the most important session of the forum. This is the session on neglected infectious diseases. My name is Michelle Hilinski. I work as a senior project officer at EDCTP in charge of the portfolio of neglected infectious diseases. So it's only fair I am chairing this session. I'm chairing this not alone, but with my lovely co-chair. Michael, do you want to introduce yourself?
Yes, good morning everyone. Michael Ramharter. I work at the Bernhard Nocht Institute for Tropical Medicine in Hamburg, and since 20 years at the Centre de Recherche Médicale de Lambaréné, and I'm very happy to co-chair with my namesake, Michel.
That's how we pick chairs. So EDCTP2, as you know, started funding neglected infectious diseases. They were not there in the first program, but we added them from the start of the second program in 2014. So I looked it up because I wanted to share some numbers. We've been making investments in 42 NID projects to a total value of 80 million euros in the second program. I think our NID projects have been very successful. They have really, they've been featured at the plenary session, some of them. I think they have done really great work, and I think we will see a really great selection of talks today, which I think all of them are part of our EDCTP-funded research groups. So with that, I would like to introduce our first speaker, which has changed a bit, because instead of Henk, we have now, I hope I remembered right, Norbert. So Norbert is not Henk, but he is working in the group of Henk. Henk could not make it. Maybe you want to introduce yourself briefly then, Norbert?
Yeah.
And I think we will be able to pull your slides up maybe by pressing on that.
Here. Let's see what happens.
Yes. Thank you. The floor is yours.
Hello. Yes. So not Henk. So for all of you who came here specifically to see Henk, I'm sorry. My name is Norbert van Dijk. I'm actually a PhD student and molecular biologist in the group of Henk. As just mentioned, Henk unfortunately couldn't make it to the forum today, so I will be presenting on his behalf. Very happy to kick off this NTD session today and tell you a little bit about the work that we are doing at the Amsterdam UMC for developing molecular diagnostic tools that can be used for diagnosing visceral leishmaniasis in remote settings. So, to give you a little bit of background about this disease, visceral leishmaniasis, or VL, is really one of the top listed neglected tropical diseases as defined by the WHO. It is a disease caused by a unicellular parasite. There are 2 species that can cause this disease. In East Africa and the Indian subcontinent, we find Leishmania donovani. And in Europe, that is the Mediterranean, actually, and South America, Leishmania infantum is causing visceral leishmaniasis. So the parasite is transmitted by sandflies, and once it gets into the human body, it will start infecting macrophages. These macrophages, will mostly get infected in the spleen and the bone marrow. And after infection, a lot of people actually will never start showing symptoms, but those who do tend to develop a very severe and potentially deadly disease. They will have chronic fever. Very typical is also the massive swelling of the infected spleen, as you can also see on the picture here of a young patient. They will have wasting and pancytopenia. It's estimated that globally there are about 50,000 to 90,000 new cases each year, but this is probably an underestimation due to the lack of proper surveillance systems for this disease. Now, the diagnosis of VL has traditionally been based on demonstration of the parasites in infected tissues, and we can do this by means of microscopy on tissue aspirates. Unfortunately, this technique has a lot of shortcomings, and I think the most important to mention here is the fact that you need to take an aspirate from these tissues, which can be very dangerous if done incorrectly. Also, the sensitivity of microscopy is mediocre at best. So therefore, there have been several efforts to develop other diagnostic methods, especially for use in more remote settings. And by now, we are mainly relying on serology in these situations. So demonstration of antibodies against the parasite. 2 techniques I want to mention here are the RK39 rapid diagnostic test and the direct agglutination test, or DAT. Now, these methods have really made it much easier to diagnose visceral leishmaniasis, but again, they also have some limitations. For example, with RK39, we see very good performance in India, but the sensitivity in East Africa is definitely a bit lower. And as you can imagine, with detection of antibodies, this approach is not really suited for treatment monitoring or detection of relapses, because antibodies will remain elevated for a very long time. And lastly, when patients are immunocompromised, for example, in case of an HIV co-infection, serology is generally unreliable. So that is why there's really a need for more accurate diagnostic tools, especially in these situations where serology is failing. Now, a solution may lie in molecular diagnosis of VL, and here then we are detecting parasite nucleic acids in a patient sample, which can be venous blood, for example. These methods are generally highly sensitive and also very specific, and they have the advantage that they can differentiate between past and current infections. Unfortunately, we have not really been able to implement molecular diagnosis of VL at the point of care, specifically in settings like East Africa. And why is that? Well, for molecular diagnosis, you need quite an extensive lab infrastructure with expensive equipment, PCR equipment, that relies on a stable power source. The personnel also needs to have more advanced training. And lastly, traditional molecular methods still rely on DNA extraction, which is making the whole process more complex and also more costly. So that is why we are focusing in Amsterdam on trying to develop innovative, simplified molecular tools that can really bring molecular diagnosis into the field. And the most important assay that we've developed is called Mini dbPCR Nalvia. This is a tool that actually was originally developed for malaria, and we are currently evaluating this in a large EDCTP funded trial. So if you're interested in that as well, please do contact me or one of my colleagues after the meeting. But today I will tell you a bit about the work that we've been doing for developing this assay for Leishmania. So first of all, it is a direct on-blood PCR that we are using, meaning that we do not need to do DNA extraction. We run our PCR on a miniature PCR device, which can be battery operated and is controlled via a smartphone. And lastly, we read out the results with NALFIA. These are nucleic acid lateral flow immunoassays. It's basically a simple dip strip that allows for a very fast and simple readout. Now, for the rest of my presentation, I will first give you a little bit more details about this method and then also some results from a laboratory evaluation that we have recently done. So as I mentioned, we are using a direct on-blood PCR. We're using a specialized PCR reagent mix that can be applied directly on EDTA whole blood, meaning that we do not need to do DNA extraction. It is a duplex PCR where we have two targets that we're amplifying. The first target is our diagnostic target. This is the Leishmania kinetoplast DNA, or kDNA. The advantage of this target is that it has a very high copy number in the parasite, so this allows for very sensitive detection. And secondly, we also amplify human GAPDH as an internal amplification control. In our PCR, we're using labeled primers, which will mean that the final amplicons will also be labeled and are therefore detectable with our NALFIA strip later on. We run our PCR on a mini PCR machine, and I took the liberty of bringing the device here with me just to show you how easy this is, and also specifically the size. So it's a very small device that can be carried just in your backpack. It can run 16 samples at a time, and a very big advantage is that it can also work on a portable power pack. So this really allows you to bring your PCR out of a traditional lab setting. Lastly, it's also quite affordable, around $800 US. That's much cheaper than conventional PCR machines. So after our PCR, we read out our results with NALFIA strips. They have antibody detection lines that can detect our labeled amplicons. You simply mix a little bit of PCR products and running buffer in a tube. You insert the strip, and then you let it incubate for 10 minutes. And then after incubation, the results can look as you can see on the figure here. At the top, you can see that there can be a test line that indicates the presence of kDNA amplicons. That's a diagnostic target. Then a test line for the GAPDH amplicons, and lastly, a flow control line for the test strip. So based on this, we can conclude that the strip on the top is an example of a sample that was positive for visceral leishmaniasis because it has the kDNA test line. The second strip is negative for kDNA, so this sample was negative for Leishmania. And the last strip is also negative for kDNA. However, it's also missing the human GAPDH test line, and when you're testing human blood, this should actually always be positive. So that is why we would consider this an invalid test where you would need to repeat your PCR. Now, after developing and optimizing this assay, we embarked on, first of all, a laboratory evaluation. And one of the first things that we wanted to know was, what is the limit of detection of our tests? And for this, we tested a number of blood dilution series from Leishmania promastigote cultures. And a second thing that we also wanted to know was to get an impression of our analytical accuracy. For this, we applied the dbPCR NALFIA to 3 sample sets from different Leishmania endemic countries. First of all, we had a set from Spain, which is endemic for Leishmania infantum. And here we tested 146 samples from VL suspected patients. Then secondly, we had a set from Ethiopia that's endemic for Leishmania donovani. Here we had 88 samples from VL patients and both endemic and non-endemic controls. And lastly, we had a bit of a smaller sample set from Kenya, also endemic for donovani. We had samples from VL patients, from malaria patients, which is another febrile parasitic disease that is also found in the area where we find the visceral leishmaniasis, and from some endemic controls. So we tested these venous blood samples with dbPCR NALFIA, and as a reference test for the Spanish samples, we used a nested PCR that is actually implemented also as the reference diagnostic test in the lab in Madrid, where we did the evaluation. And for the East African samples, we tested these in Amsterdam with our in-house kDNA qPCR. And these are the results that came out of this evaluation. So first of all, we found a limit of detection of 650 parasites per milliliter of blood for Donovani and 100 for Leishmania infantum. And I think most relevant here is how that translates to our accuracy. And I first want to draw your attention to the first row for Spain, where we see that we had a very good sensitivity of almost 96%. And a specificity of 97.2%, so really excellent performance for diagnosing Leishmania infantum. In East Africa, we had perfect specificity, so both in Kenya and Ethiopia, we did not have any false positives, so I think this is very promising. The sensitivity was good, however, a bit lower than in Spain. It's around 86 to 89%. After a closer look at the parasite densities of the samples that we missed with dB-PCR and Alphia, we also saw that the parasite quantification that we saw in the blood was close to the limit of detection for Leishmania donovani. So this might have been an explanation why we missed these samples. So with that, I come to the conclusion of my talk, and I hope that I've convinced you a little bit that dB-PCR and Alphia is an easy and fast platform that requires very few resources and could really be having the potential to bring molecular diagnosis of Leishmania to remote endemic settings in East Africa, for example. We see that's very accurate and sensitive and in low parasite densities. However, for East Africa, it might be necessary to optimize the limit of detection a bit more to further increase its sensitivity. And maybe to finish with some outlook of things that might be interesting to evaluate is to see if we can also apply this test for treatment monitoring, because there is a very high need for a test of cure for visceral leishmaniasis, which we currently do not have. And a separate evaluation in immunocompromised patients where serology is not performing very well would also be interesting to do. And with that, I'd like to finish, not before thanking, of course, all my colleagues in Amsterdam who collaborated, also colleagues in Madrid, Professor Wolde, who obtained the EDCTP funding for this research, and lastly, the colleagues in Kenya who helped with the sample collection. Thank you for your attention.
Thank you, Norbert, for an excellent presentation. So I'm sure there are questions. If you have a question, raise your hand. And I think there's a microphone somewhere. She's coming. Because I think if we put in the microphone, people online can hear it. Ladies first.
Thank you for your nice presentation. I am member from Ethiopia, Ahri Armauransa Research Institute. I want to ask, the DNA of the parasite can stay longer in the patient. So how do you see this, the possibility of identifying the past and the present infection if the DNA stay longer?
Yeah, so that is a very good point that you raise. I think there have already been a number of studies showing that with a very sensitive qPCR, you do see a decline in DNA values in the blood. A lot of patients turn negative. As a matter of fact, we also had a very small sample size, but a number of patients from Kenya that we followed up during treatments. And we nicely saw that by the end of their treatment, that's after 17 days, they were all negative with our dB-PCR and Alphia. I think what might actually be an advantage here of this test maybe being not as sensitive as qPCR is that it could actually be very well used without detecting these very small residual DNA particles. Yeah.
Other questions?
Thank you for your nice presentation. I just wanted to know, in malaria, some labs experience long-lasting people who stay after treatment which are positive with they use multigenic genes to DNA, and people stay positive with DNA, and they know they treat them, and this has imported malaria to France, and people are monitored, and so do you think it has to? What can you do if the person stay positive to?
Thank you.
Instead of treatment.
Do you would you like to know for malaria or for visceral leishmaniasis?
I mean maybe the same problem will have with malaria. We are seeing that. So with leishmania, I think the DNA, maybe there is some DNA stay even the infection is not active.
Yeah. So I think that links a little bit to the question that was just there. Something that we definitely still have to evaluate. So a more elaborate evaluation of treatment follow-up samples, seeing for how long these patients stay positive with qPCR, whether we're also detecting this with mini-PCR, is definitely important to do to assess whether we can really use this for treatment monitoring. What I think, sorry, I just forgot what I wanted to say. I think that's for now. At least in the end, it will also. That's what I want to say. You shouldn't only look, I think, at the results of this PCR. You should also definitely look at the clinical picture of the patient. Does it match with visceral leishmaniasis or malaria?
And are you going to look at the RNA? I mean, do the same test with another step before with RT-PCR that can more demonstrate an active infection?
Yeah, I think that as a kind of reference test, that would definitely be interesting. Whether this platform is also suited for RNA detection, I think potentially it is, but you would need to design a different PCR protocol, of course. But maybe something to consider. Yeah.
And finally, I guess everything is protected, and which polymers are able to work with hemoglobin directly on the blood. So I think there is.
Well, actually, this work that I just presented here, we've submitted it to PLOS NTD. It's currently under review, so hopefully it will be published soon. And there are also. We just get our reagents from biotechnology suppliers. It's just really the combination of the different aspects that's kind of the innovative aspect, and as well as, of course, our evaluation of this test. And for the malaria work that we have done, actually, the lab evaluation that has already been published in Malaria Journal. So if you're interested in more details, I can definitely refer you to that paper. Yeah.
On the reagents?
Yeah, also on the reagents.
Thank you.
Yeah.
Thank you.
Great. I think we have time for one more question behind you. Yeah.
Yes. Thank you. Great presentation and great product. Congratulations to all of you who worked on this. And most of all, fits the need for on-site diagnostic, also for other diseases. So do you think that for bacteria or for viruses, the device would need adaptation, different reagents? How much of an adaptation cost and time would you figure out would be needed for that?
Yeah. Thank you for your question. I think optimization of a PCR, especially this one, because it's a little bit more simplified and you're working with blood, still a little bit of a black box. You don't know exactly what might be interfering. So it's a bit of an, the process can be a bit unpredictable. But just to give you an impression that it took us maybe half a year to go from our malaria assay that we first developed to a leishmania protocol. So that's definitely also a strength of this tool. I think that it is definitely very flexible. And for example, now we're also considering, can we develop something similar for Helminth infections on stool samples? So that's, in my view, it definitely has this potential, maybe also for bacteria and viruses. Yeah.
Thank you. There's a final question, and then there maybe is more time at the end to ask more questions. But we do one more question, then we move on, and then we see if there's time at the end.
Okay. Hello, thank you so much. I'm B. Chendu from South Africa, Stellenbosch University. Quite an interesting talk there. So I just have one question because you already answered the other ones. What volume do you need, blood volume do you need for the assay?
Yeah, so you put 2.5 microliters in the PCR, and that's what you directly detect. So in this case, we used venous blood samples because that was already being collected as a standard part of care for these leishmania patients. But for our malaria assay, we're just collecting a little bit of finger prick blood, and that works very well. So, yeah.
Thank you. Let's get the microphone back, and let's thank Norbert for a great talk.
So it's very good to see that there is so much interest, so many questions. I'm sure over lunch we can discuss a bit further. The room is also filling up, which is also a very good sign. And we are coming to the next difficult to diagnose disease, which is schistosomiasis. And Dr. Högstra will tell us a little bit more about CAA and CCA diagnostics.
Do I just click on the...
Click,
yes.
Oh, sorry. Yes, thank you so much for this introduction, and also thank you for the opportunity to present here. So I'll be presenting on behalf of the Free Billy team. We've been working in our Free Billy study on easy-to-use diagnostics for the elimination of bilharzia, also known as schistosomiasis, and in particular focusing on young children and mothers. And today I'll be focusing on the development of a CA-CCA duplex test. So just a little bit background on schistosomiasis. It's a parasitic disease. It's a neglected tropical disease. And more than 200 million people are infected worldwide, and even more are at risk of the disease. And the majority of them live in sub-Saharan Africa. People become infected by coming in contact with contaminated water. So majority of risk groups and affected populations are women and children, but also fishermen and other people who are working with water. There's two forms of the disease. There's the intestinal form and also a urogenital form. And another one that has received a lot of attention lately is female genital schistosomiasis. For the prevention and control of schistosomiasis, the WHO recommends treatment for those who are infected, and the treatment available is praziquantel. And this is usually given in the form of preventive chemotherapy in mass drug administration programs to school-age children, and depending on the prevalence, also to a wider public. And in addition to that, you can also do snail control, environmental management, health education, sanitation, and also access to clean water is very important. So recently, the WHO published a roadmap for the elimination of neglected diseases by 2030, and schistosomiasis is one of them. And there they stress also that the development of accurate diagnostics is really important, and that is what our project was focusing on. So currently, still microscopy is used quite a lot for the detection of schistosoma infections, and mainly to detect the eggs in stool or urine samples. It's high specific, it's quantitative, you can count the number of eggs, which is related to the morbidity, and it's relatively simple and fast. But it has its limitations, as Norbert also mentioned, for the VL, but here for schisto it's the same. We have a limited sensitivity, especially in low-intensity infections. There is quite a few cases that are missed. Also, post-treatment monitoring with microscopy is difficult. There's a high fluctuation in egg excretion, so you can have a lot of eggs in urine on one day, but then very few the next day. So you need multiple samples to get an accurate measurement of the level of infection, the intensity of infection. Also, it's quite labor-intensive, and you need trained technicians. So we use it often as a reference test, but it's not an accurate gold standard to compare other diagnostics to. So as an alternative, in Leiden, we've been working on antigen detection, which are schistosoma-specific antigens that are regurgitated by the adult worms. And it's already described in 1976, so a couple of decades ago. And we focus a lot on CCA and CAA, two circulating schistosoma antigens that are detectable in serum as well as in urine. They are reflecting active infection, so after exposure we see an increase in antigen levels. as well as a decrease after treatment. We have two different tests for these antigens available. We have the POXI-CA test, as indicated here, a rapid test. It's commercially available and produced in South Africa, and it works mainly for the intestinal schistosomiasis. It's very field applicable and user friendly. And in addition to that, we have the UCP-LF-CAA test, which is a lab-based test shown on the right below. It's very sensitive and it's highly specific, but it's still based in the lab and not yet ready to be used in the field. So within our Free Billy project, we wanted to evaluate the sensitivity and the specificity of these two antigen tests in two different regions, one for where Schistosoma mansoni is endemic and another one where hematobium is endemic. And we focus particularly on pregnant women and young children, as these groups are often excluded from control programs, and they are actually still a source of, they continue the transmission of the disease. And also they are at risk for schistosoma-related morbidity in case of the women, mainly also FGS, and in case when they're pregnant, also poor infant outcomes such as premature delivery and low birth weight of the baby. So within our Free Billy project, we had two main clinical trials. One clinical trial in Gabon, where we used the lab-based CAA test to evaluate the efficacy of praziquantel in the schistosoma hematobium endemic region. And then we had a large cluster randomized trial in Madagascar, where we implemented the POXI-CA, so the field applicable test, in the schistosoma mansoni area for a test-based treatment strategy in pregnant women and newborn children. And then in Leiden, we coordinated the project and we were involved in the antigen diagnostics as well as the development of a duplex test, which I'll be focusing on for the rest of my talk. So we focused on developing a lab-based test. We wanted to combine the best of the two tests, so the POXI-CA on the one hand and the lab-based CAA on the other hand. And we for that, we used the UCP platform that has been described for the CAA test, but we now also applied it to the CCA. And in addition to that, we also wanted to explore whether we could say anything about the species, because both CAA and CCA are excreted by all schistosoma worms, so we cannot differentiate between the species based on the detection of either antigen, but maybe a combination of the antigens, as has been observed and also published previously, could give an indication of the species that we are dealing with. So we wanted to explore that as well. So when developing this duplex test, we came across different formats and different formats available to detect two antigens at the same time. And in the end, we focused on this format number 5, which was the main reason because a new reader became available, which actually could fit these cassettes that have two singleplex test strips that can detect both antigens simultaneously, and also because of the ease of production and the production cost, and also potential acceptability for external manufacturing. So within our biobank of samples at the LUMC, we selected 2 sample sets which had matching serum and urine samples to detect both these antigens in both sample types from the same individual. So for schistosoma mansoni, we selected a sample set from Senegal, and for schistosoma hematobium, we selected a sample set from Cameroon. And you can see the individual results of the CA and the CCA on this figure here. So on the left side, you see the results in urine. And then the first two blocks are from the CA and the CCA from the schistosoma mansoni. Let me see. Can you see my mouse? Okay. So you can see here in the schistosoma mansoni set in the urine samples that there is a lot of CCA detected in the urine compared to the amount of CAA that's been detected in the urine. And for the schistosoma hematobium, this difference is actually not the same. So perhaps giving an indication already to detect specific species. But then if we look in the serum samples, we could not see this difference between CA and CCA in the schistosoma mansoni, but also not in the schistosoma hematobium sample set. So we also looked at the correlation between the two antigens. in the different sample types and in the sample set. So this is these two figures are shown for the Schistosoma mansoni sample set from Senegal. So on the left-hand side you see CAA compared to CCA in urine, and then on the right-hand side you see CAA compared to CCA in the serum. And here again you can see this obvious difference between a lot of CCA in the urine compared to CAA, which is different from what we see in the serum samples. And then for the hematobium, again, here you also see that there's quite a bit of CAA in both sample types, but less CCA. So now we wanted to look at the ratio between CAA and CCA to see whether we could detect or have an idea of the species that we're dealing with. And for that, we took the quantifiable measurements within these green areas, so that we had an accurate measurement of the CA and the CCA levels, and those we used to determine the ratio. So the ratios are indicated in this figure, and here you can see that in case of the urine samples in the Schistosoma mansoni sample set, there's actually 100 more times CCA in urine detected compared to CAA in urine, and that this difference is not observed in serum. So to conclude, with this study, we've generated data that there's an added value of combining the detection of the two antigens. In particular, for the Schistosoma mansoni, we can see that actually by detecting CCA, we detect a lot of infections, but still, if we add CAA detection, we can see we have more positives. And for hematobium, it's the other way around. We detect more CAA, but still with CCA we can detect additional cases that were not detected by CAA only. But of course there's also some limitations and some things to further investigate. I think we still need to test in larger sample sets and also maybe from different endemic regions to be able to really say if we can identify the species based on the ratio. And this is also to do with the sample type, so we did observe differences in urine, but we didn't see that in these sample sets in the serum samples, but also the age of the individual and clearance mechanism could play a role in the excretion of CA and CCA in the serum or the urine. And in addition to that, also the type of assay, so for this we used a standard assay, but to get more accurate levels of antigen, we could either concentrate or dilute the sample to get a better and accurate measurement of the CA level. And also, just to mention that there is a difference in study population between the two country sample sets that we took. In Senegal, we had a community-based study, while the Cameroonian study was only in school-aged children. And also, these were pre-treatment samples, so they were pre-selected based on egg positivity, and preferably we would test it further in a bigger sample set, which has no pre-selection. And before I conclude, I just want to highlight the other results of our Free Billy project from the clinical trial. Some preliminary results are presented as posters, so please visit our colleagues that are presenting. And with that, I would like to thank EDCTP for the funding and also all the partners in the consortium for their help. And if there's any questions, I'm happy to take.
Thank you so much for this nice presentation. I see it's quite complex that now the CCA in urine is higher in the Mansoni group. It would be so much easier to remember if it would be in the hematobium group, which is the urogenital schistosomiasis. So, but it's not your fault, I guess. So I'm sure there are a lot of questions.
Thank you very much for your presentation. Your focus is majorly on S. mansoni and S. hematobium. You didn't mention S. japonicum. I don't know if there are no cases of that where you are carrying out your primary treatment. Thank you.
Yes, thank you for that question. So for now, the focus was on mansoni and hematobium because these sample sets were available. But we know, in particular, the POC-CCA test, or the point of care, it works for intestinal schistosomiasis, so also for the Japonicum. And I think the CAA test can detect all the different species. And we've also demonstrated that, for example, in China or in Cambodia, that other species can be detected as well. But we didn't use that for this evaluation.
Thank you for your presentation. It was, I joined for this, the last question. There is also in Africa many hybrids between Hematobium and bovis or other species. So maybe it will be better to include to the test those infections.
So also for that, at least for the CAA, so the lab-based test, we are also able to detect hybrid species, because they have been confirmed with PCR that it's a hybrid, but with a CAA test we cannot differentiate. So we know it's schistosoma, but we cannot say which species it is, but we know we can detect also the hybrids.
Okay, thank you. So the PCR is the gold standard that you are
So we use the CAA to confirm whether people are infected with schistosoma or not. And in one study in travelers, we knew that based on sequencing that it was a hybrid infection between schistosoma hematobium and Mattei. But we could detect them all with the CAA test, but we couldn't tell which species it was.
Can develop.
Maybe just one stupid question. Why do you actually emphasize so much the differentiation between the species? Because it is often obvious from the clinical presentation or epidemiological setting. So why are you so much interested in knowing whether the test can differentiate between the two?
Yes, thanks for that question. So I think it's important. Our work is a lot on the antigen diagnostics, so detecting the worms basically, so reflecting active infections. And I think to be able to compare with microscopy that you can differentiate the species, it would be interesting to see whether based on the antigen we could also have that additional information, even though we probably know from the region or if which species is endemic. But if both are endemic, we cannot say which one it is just based on the test.
I think there was first a question in the back, and then we come to you.
Thank you for that wonderful presentation. I'm Johnson from Nigeria. I did a seminar work on schistosomiasis, which is very endemic in our country. I want to ask if in the course of your microscopic analysis, is there any report of ectopic egg elimination? Thank you.
Yes, thank you for that question. So within our project, we do not focus on microscopy, but our focus is on the antigen diagnostics. But I think it has been described that there is ectopic egg presentation, yes.
Thank you, Piche, by presenting our work here. I have some concern, which I raised for more than 10 years now, with lizards particularly. It's regarding the gold standard diagnostic test. When I saw you in your background information, you put G of gold standard in the parentheses, which is, I don't understand why microscopy, which is still in the gold standard for us in Africa, of course, which is the same here, I guess. Why do you mitigate this qualification of gold standard for microscopy?
Thank you for that question. So the reason we do that is I know it has been thought of a gold standard, and in particular it's used in a lot of countries in Africa, of course, the microscopy, but we think it's very difficult to, if you have a new diagnostic test, you want to be able to compare it to a gold standard. But if the gold standard lacks sensitivity, it's very difficult to be able to get an accurate idea of what the sensitivity of your test is. So with that, we want to refer to it as a reference test and to include other tests as a reference to be able to develop new diagnostics that are more accurate.
Yeah. Do you have any reference test which can replace microscopy today? If I look at the limitation of what we have done with CCA and CAA, even including the identification of species and so on, do you think there is already a gold standard test to replace microscopy?
No, I don't think so. What we do is we use a combination of different tests that we know are highly specific. So, for example, we have a combination of microscopy and PCR, and then we combine our antigen test to that.
So there is time for a final question, if there is any more. And if not, then we shall thank Dr. Huxler for this very nice presentation.
Thank you. Because this is an NID section, we keep switching diseases, and we are now also going a slightly different direction. Again, we're going to talk about leprosy. I would like to welcome to the stage Dr. Nelly Mwajeni from Tanzania, who's going to present to us some great work done under a nice project, PEP4Lab. I'll let her introduce herself further. I think if you click on the box with your slides, they should come up. Perfect. The floor is yours.
Thank you very much. My name is Nelly Mwageni. I'm a dermatologist, and also I'm a PhD student from the PEP4Lab project in Tanzania. So I'd like to take you through, on behalf of our PEP4Lab team, on the preliminary results on the skin diseases and their frequency pattern in PEP4Lab implementing districts in Tanzania. So just a brief introduction. 3 out of the 10 most prevalent diseases are skin condition, and the burden is high in sub-Saharan Africa. Neglected tropical diseases, these are a group of undervalued diseases that manifest mostly in tropical region, in particular in resource-poor setting. They are still endemic in some areas, and some of these diseases are manifesting on the skin. So because of their high prevalence, integrated examination approach can be an ideal way to detecting these skin-related entities. This is also promoted by WHO, which emphasizes on combining or integrating approaches targeting multiple skin entities at the community level. So just a short introduction on PEP4Lab. This is an implementation research project which is taking place in Ethiopia, Tanzania, and Mozambique, which is aiming at combining integrated skin screening approaches and leprosy chemoprophylaxis provision, administration in leprosy contact at both community and household level. So in Tanzania, this project is taking place in 3 districts of Morogoro, Mvomero, and Lindi. These are among the top 20 districts that reported high prevalence of leprosy. And last year, we had around 1,700 leprosy cases in Tanzania in general. So the aim of this project is to contribute on interrupting the transmission of leprosy by identifying the most effective and feasible method of screening people at risk of developing leprosy and then administering post-exposure prophylaxis. In this case, it's SDR single rifampicin, SDR PEP. So what is going on? This in PEP4Lab project, this is a 2-arm cluster randomized implementation trial whereby integrated skin screening is on the leprosy contact is going hand in hand with the provision of SDR PEP. It is comparing 2 intervention 1 and intervention 2. Intervention 1 is a skin camp intervention whereby contact from the 20 closest houses from the near the house of the index patient are invited at the community level for screening and provision of SDR PEP. While intervention 2, this is involve the screening of the household members, those who are living under the same roof with the index patient, who have lived for at least 3 months. And this intervention, the index patient is asked to invite their contacts into the nearby health facility for screening. So this is a conventional way which is doing in most of the cases. So for this preliminary result, we are presenting the result from the 3 districts, Morogoro, Mvomero, and Lindi, with the data taken from January 2020 to July 2023. So skin screening, the skin camp intervention were performed by dermatologist or a trained dermatological trained medical doctor, while screening at the health facility were performed by a trained health worker with an option to use NRL Skin app. This is a mobile phone application which was designed to help health workers living in a remote area to provide diagnosis and managing common skin diseases, including skin NTDs. So also these health workers were able to contact direct dermatologists in case of a difficult skin condition. So these are results. We have made it to screen 6,100 contacts from both intervention 1, intervention 2. 93% of these contacts were from the skin camps, while 7% were from the health facility. So majority of the screen contacts were female, and with the age range from 0 to 100 years, with mean age of 27. 51% in general from the both intervention were having skin diseases. So results from the health facility intervention, we screened around 425 household contacts, and from there, 18% of the screen contact had at least one skin condition. 1.6 of all contacts screened in the health facility intervention had leprosy, while 17% had other skin condition. 10 different skin conditions were found among the screen contact, and out of the 80 skin diseases found, majority were the superficial fungal infection, which were observed in around 66%, followed by eczema category, and there were 3 scabies. So from the skin camp intervention, we managed to screen around 5,675 community contacts, whereby 54% of the contact within the health skin camps had skin diseases. 0.6% had leprosy, and 53.6% had other skin condition. And surprisingly, 12.7% of all contact had at least more than 2 skin conditions. So a total of 56 different skin conditions were observed among the all screened contact. And so in total, we had 3,425 skin diseases found among the contact who were screened. Majority of the skin conditions found were infectious and infestations, followed by eczema category, and other miscellaneous skin conditions were found in about 11% of contacts. So this is how the skin camps looks like. It was really set at the community level. You can see how we improvise the screening area for screening of skin diseases. And here for all those patients who were found with common skin condition, we are made to be provided with topical medication. But for those patients who were found with leprosy, we are also channeled for proper treatment and insertion of leprosy medication. And for those patients who had eligible for the reception of SDRPEP, we are provided with SDRPEP. So these are among the top 10 skin conditions found during the screening. We have, as I've seen, the most of the people were in the category of infection and infestation. And here, tinea capitis is infection of the fungal infection of the scalp or the leading disease encountered, and it was found in a 27.7% of all contact with skin diseases. It was followed by pertussis vesicola, tinea corporis, but also scabies were there, and other diseases as shown in the table. And these are some of the skin NTDs which were encountered during the screening of skin diseases. And a total of 271 skin diseases were encountered. Majority were scabies, which were counted at around 83% of all skin NTDs found, followed by leprosy, and also encountered some deep fungal infection, onchocerciasis, and lymphatic filariasis. So to conclude with, I would like to say that integrated skin screening increases the diagnosis of a range of skin conditions in communities, including skin NTDs, such as leprosy when conducted in endemic areas. Preliminary findings showed a higher detection percentage of skin condition in camps compared to the health facility intervention. Combining integrated skin screening and leprosy prophylaxis administration seemed to be feasible also at the community level. Since pay-for-lip recruitment is still ongoing, we'll perform an in-depth analysis at the end of the project. This will also include cost effectiveness analysis of both intervention. In this, several factors impacted this project, including COVID-19, whereby we faced a lot of travel ban and ban gathering, which completely impacted on the community skin camps and medication shortage and health staff transfers. So we have applied for a project extension via EDCTP 3. So at the end, I would like to acknowledge all our consultants, funders, and all members who have made this project possible. Thank you.
Thank you so much for this great presentation. I'm now inviting you for questions. I see a hand up. Let's start here.
Thank you so much for that work and great presentation. Just a curiosity, you know, you are a specialist and likely in this project you were working with, you know, relatively less trained health workers or community health workers. I would like to hear your reflection on their performance. I think that is important for then, you know, a strategy like that being taken up. And you mentioned also the cost effectiveness, if you have an idea how that can be uptaken by the Ministry of Health as a routine activity. And finally, you know, at least in the northern Mozambique, there are external shocks for field work like that. So how did you cope with, you know, all internal displaced people because of, you know, war that is ongoing there? Thank you.
Well, thank you very much for your question. Maybe to start with the first one. Yes, especially in my country, we have a very low number of dermatologists, and these research also involved the screening of skin diseases. So what we did at the first, we conducted training for health workers and also for those who will be participating on the skin screening. So we impacted with the knowledge, but also personally I was available in most of the skin camps to conduct the screening. But also I managed to do myself the on-site training for when I'm there for the other medical officers who are joining the skin camps together. So actually we see a lot of improvement on the performance in the screenings for skin diseases, most of our health workers. And that really we thank for the project as we get down to the community and we help the health facility and the community level to be comfortable in diagnosing of the skin diseases. Maybe to talk about the cost effectiveness, yes, we know that the main aim of the Pay-for-Lip project is to find which is the feasible and effective and way of providing chemoprophylaxis to the contacts of leprosy patient. We know that with the community skin camps is somehow expensive, but we reach more people at the community compare the conventional way of inviting contact from the household members to come to the health facility to receive chemoprophylaxis. And by maybe just by surprising, we initially we assume that at least 6 household members will be coming for the screening at the as facility through the invitation from their index patient, but surprisingly, it's around 3 to 4 contacts from the household coming for the screening. So you can imagine. So both ways, really, you like to see the final result at the end, what will tell us. Oh, the last one? Oh, I forgot. There was another question.
Thank you very much for your presentation. I remain Patrick Agbu from Nigeria. They said prevention is better than cure. You made mention of chemoprophylaxis in your treatment. And some of these diseases are water-related and water-washed. I don't know, what is the source of water for bathing and probably even drinking for this group of people you are working on? Is there anything you are also doing in terms of providing portable water, having good source of water for them, because that could be a very high contributing factor to some of these diseases? Thank you.
Oh, thank you very much for your question. Actually, during provision of chemoprophylaxis, the content also receive water, but we are making sure that the water is safe and treated before they are taken for drinking during the takeoff for the medication.
Thank you for your nice presentation. So you mentioned two things. You mentioned that you have a shortage of dermatologists, as well as you provide, irrespective of their infectious status, you provide 2 contacts PEP, which probably is the SDR PEP, isn't it? So single dose rifampin in a TB endemic area. So would it be useful also to implement a diagnostic test, for instance, if you don't have dermatologists, so that you would know the people and confirm their status of infection, for both for suspect disease as well as for those that you're going to provide with a single dose of rifampin, to see whether they even need it, because a single dose of rifampin has been shown to have an impact in new cases, but it's not shown at all to be effective for people who have high dose infection.
Yeah, thank you very much for your question. Actually, with the PEP4Lab project, we also have a skin app to support diagnosis for skin diseases, especially when the dermatologist is not there. So, in this app is intentionally made for supporting the health workers with low knowledge in dermatology. And it's really supporting, and we have really good news for this app. Like, it has more than 60% sensitive to pick up skin diseases, and it's really useful. It can be used also as a training tool. It has some relevant information and data to support during their leads, and also like it's really supportive for health workers.
Thank you. Are there more questions?
Francis Ekin from Cameroon. Thank you, Nelly, for your kind presentation. And I work on Bulurosa, and we've been able to implement the dermatology in Ghana and Cote d'Ivoire. So I want to hear about your experience of using teledermatology in Tanzania. So your teledermatology, how good was it to differentiate among the different skin diseases? And now, after that first screening, which confirmatory assay do you put in place to validate the different results obtained? Thank you.
So the skin app for use in Tanzania, it has been validated 2 times in Ethiopia, in Nigeria. Yeah, so we use the third version of skin app still under validation stage. So we still have work to do on it. So, but still useful. Comparing not to have a dermatologist in the app at all for the health workers.
Okay, if there are no more further questions, let's thank Dr. Marjani for her excellent talk.
So now we come yet to another disease, soil-transmitted helminths, and now also another study methodology about a treatment trial for soil-transmitted helminths, and it's my pleasure to introduce Jose Munoz from Barcelona.
Thank you very much for the introduction, and good morning to everyone. My name is Jose Munoz from Barcelona. I'm speaking today on behalf of the STOP consortium funded by EDCTP. And I would like to share some preliminary results of the ALIVE trial. The ALIVE trial is one of the main components of the STOP consortium, of the STOP project, and it's basically designed to evaluate the safety and the efficacy of a novel fixed-dose co-formulation, including albendazole and ivermectin as a single dose and a 3 consecutive dose for the treatment of STH, soil-transmitted helminths, basically. So I didn't include a slide with the cycle and the impact because I know you are all NTD experts, so you don't need it. But I included this slide showing you the main pillars for the control of STHs, which is, as you know, mass drug administration, so providing albendazole and mebendazole to population at risk, basically school-age children, but also women at reproductive age and pregnant women, and also water, sanitation, and hygiene. And we all know also that there are some defaults of the mass drug administration that challenges the progress from control to interruption of transmission of STHs. And this is where the STOP project is trying to focus, basically on the last 2. There's a lack of efficacy of albendazole and mebendazole to treat all species of STHs, basically Trichuris, Trichuria, and also Strongyloides stercoralis, a bit of hookworm also, you will see. And also there's the concern of the emerging of drug resistance because we're treating widespread in monotherapy, and we know from the veterinary field that drug resistance may be a huge problem in the future or probably in the present also. And concerning drug efficacy, you can see this very nice meta-analysis evaluating the efficacy of albendazole. You see at the top for Ascaris lumbricoides is still well conserved. It's above 95%, a bit less for hookworm, and less for Trichuris. So basically, the problem is that the efficacy of albendazole and mebendazole against Trichuris, which is the main outcome of our trial, has decreased over the last decades. There's the possibility that also resistance, anthelmintic resistance, could contribute to this decreasing of efficacy, and Strongyloides hasn't been even contemplated in mass drug administration campaigns until recently that WHO is trying to address this gap. So the solution that the consortium proposed was the fixed-dose combination of ivermectin together with albendazole to give the benefits of a fixed-dose combination in terms of logistics and costs and delivery and others, and also the benefits of providing 2 drugs that would probably solve the problem of efficacy and resistance for all the species, for the 5 species of interest. So when we started to work in this project many years ago, we had to go through 4 different steps. The first, as you know, ivermectin is prescribed as a dose adjusted by weight. So we need to evaluate the safety of the fixed dose of ivermectin, because otherwise we can't co-formulate the drug, because albendazole is already in fixed dose. The second one, to complete the pharmaceutical development of the tablet, which is an orodispersible tablet, and the bioavailability. And within the STOP project, we demonstrated the safety and the efficacy of the FDC and the regulatory pathway, which I have to say that we have been doing within the STOP consortium an intense activities within the EMA, 3 different scientific advice to make sure that we are aligned with the regulatory bodies in parallel, but in which we are also doing the clinical trial. So we think that's really important for our project. So since the ivermectin must or should be adjusted by weight. The first step we did was to do a crossover clinical trial with 54 healthy volunteers in Barcelona, in which we provided ivermectin as prescribed, adjusted by weight, and then fixed doses, 18 milligrams and 36 milligrams. And I won't show you the results now, but you have to believe me that fixed doses of ivermectin 18 and 36 milligrams were completely safe to healthy adult volunteers, up to 700 micrograms per kilo. And then we have a lot of literature published supporting this evidence. And now with COVID, you know that ivermectin has been tested in very high doses, so we saw really the safety of ivermectin. There's an increased availability of the high doses, which is clear, so we get the green light for co-formulation. So we can have now ivermectin in fixed dose to co-formulate with albendazole. And then the STOP consortium, we managed through EDCTP to create an excellent group of researchers in different countries. Some of them are here in the room: the Netherlands, United Kingdom, Spain, Ethiopia, Kenya, and Mozambique. And also, there was one partner, which was Liconsa Laboratories in Spain, which was critical for the development of the tablet, basically, and also for the clinical development plan and the regulatory activities. The structure of the program was surrounding the clinical trial. Besides capacity building, we have an intense work with the Netherlands on molecular biology, not only on PCRs, but also on the evaluation of anthelmintic resistance through genomic approaches, and also on modeling studies to evaluate whether it would be cost-effective to implement this kind of tablet in mass drug administration in different scenarios. So, this is basically the scheme, very simple, of the trial. It was a randomized, controlled, adaptive phase 2 and phase 3 clinical trial. We designed an adaptive trial because we needed to provide data on the safety of the FDC before embarking into the efficacy trial. So we analyzed very quickly the data on the phase 2 trial, which was the main endpoint was safety. The DSMB gave us clearance for moving into the phase 3. And the data on the efficacy of participants of the phase 2 were also included in the efficacy data, in the efficacy cohort. We did that trial in 3 different countries: Mozambique, Kenya, and Ethiopia, and for 3 different species. Trichuris, which was the main endpoint of interest, and also hookworm and strongyloides, which is, as you know, the most neglected of them. We designed a school-based trial in which we recruited different participants after informed consent, and we randomized them in different schemes for albendazole, fixed dose combination, and 3 consecutive doses of fixed dose combination. The main endpoint was cure rate 21 days after treatment, and was evaluated at school level, also safety. This is the trial profile, in which you can see that we screened more than 4,000 participants, and 1,000 were randomized, and finally 974 participated or completed the study. And this is the table of the baseline evaluation population, just for you to see that the 3 different treatment arms were balanced in terms of the main characteristics. But I want you to highlight that there were different numbers for the different species, because we did the different sample size calculation for the species depending on the expected efficacy. Most of them were trichuris, 636, hookworms, and we were expecting to recruit a higher number of strongyloides, but that was a challenge in the trial. We didn't make it to complete the sample size because an unexpected low recruitment rate in Ethiopia, which was the site where they had more strongyloides, and also because a situation of civil unrest. So we concluded a bit underpowered for strongyloides, and I will show you that these have a bit of impact in our final data. The FDC is an orodispersible tablet that dissolves very quickly in the mouth, so we expect that we will decrease the risk of choking that we have sometimes with albendazole, and it tastes mango and orange, and I have tasted, and it's very good, actually. So yeah, it's like a candy that's also challenging. And very few participants classified bad, and none of them very bad, the palatability, which is, I think, a very good scenario. Concerning the summary of adverse events, there's a numeric increase of the number of adverse events, albendazole compared to fixed dose, single dose, and 3 dose. But most of them were gastrointestinal. The nervous system were headache, all of them mild and really self-limited. So we didn't, as you can see at the end, see any severe adverse events in the study population, in the safety population. So we concluded that even though there's an increased number of adverse events related to the drug, none of them were severe. Main outcome, efficacy against tricuris. The cure rate, 35% for, I don't see the pointer, 35% for albendazole, 82% and 97% for the 3 consecutive days, which was very nice. And there were clinically significant differences between the 3 study arms. And we're happy because this was the main outcome, as you can see in the different figures. For hookworm is a bit different. We see also differences, but main difference was between the 3 consecutive arms and albendazole. But there's only a numerical difference, which I don't think it's clinically significant, between the albendazole and the FDC single dose, which is a bit what was expected for hookworm because ivermectin is not expected to have high efficacy. And this is the data for strongyloides. As I said before, the trial was underpowered. And also, we know very well that the Berman technique, which is one of the highest quality that we have, but still is not a very good method to evaluate cure. So we saw, again, a numerical difference in the cure rate for the different arms, but it was not clinically significant. So we're eagerly waiting for the results of the PCR to see if we can shed some light on what happens here. Of course, we know that ivermectin is the drug of choice for strongyloides. So, I mean, clinically, there is no doubt that adding ivermectin to this component would be a very good thing for strongyloides. Last slides. We thank everyone, especially EDCTP, for this project, which is developing an innovative fixed-dose formulation with a potential impact in public health. We think that can greatly contribute to move from control to interruption of transmission, given the data we have already. We have been able to build a strong partnership for conducting clinical trials in NTD, which I think is also very important. A novel partnership with the academia and pharma, which really ensure some of the objectives of the trial, and we did a lot of efforts in doing all the regulatory activities in parallel to the clinical trial. I think that's important also, because otherwise we will end up with a publication and nothing else. So what remains to be done? We need to go for effectiveness, pragmatic trials, what's happening in real world, not in a controlled trial. And we have to start the process of registration, not only in EMA, but also in African countries. And this is why we are happy to say that we have another stop funded also by EDCTP, in which these are the main endpoints. We're also evaluating safety in a larger population in 20,000 school-age children in Ghana and also in Kenya. Finally, I would like to thank very much the consortium for the strong work they have been doing over the last 5 years already and more. And I'm here for any question if you may have. Thank you very much.
Thank you, Jose.
Thank you.
I see already some hands up.
Which one first?
Maybe Umberto?
Thank you very much for your very interesting presentation. I'm Umberto D'Alessandro, MRC Unit de Gambia. I'm sure you expect my question.
Hopefully, yes.
Yes, so as you know, ivermectin has been recently, relatively recently, studied also for interrupting transmission, or at least as a vector control intervention.
For malaria.
You know, and the fixed dose combination with albendazole is probably something that could be also considered for that, right? Yeah. So, and you target only school children, I think. So the issue is what first? What's your thought about the use of fixed dose combination for malaria as well, and combine the two? You know, the two diseases in a sense, you know, soil-transmitted helminths and malaria. And also, if the fixed dose combination you think can be used also for more older children or adults, because you talk about interrupting transmission. So I'm not sure if you can interrupt transmission just by targeting children. Thank you very much.
Thank you, Umberto. Well, we are all in favor of integrating activities to fight NTDs and parallel other diseases that are not NTDs. We know that there are some studies trying to assess whether ivermectin can be, as a vector control strategy, can interrupt transmission in some areas. The challenge with preventive chemotherapy in STH is that if we follow the actual schemes, is given annual or biannual. The half-life for ivermectin is quite short, and we evaluated in the study that is showing healthy volunteers that even if we give 36 milligrams, we can prolong the availability of ivermectin for up to, I think it's 5 to 6 days. I think the mosquitocidal activity of ivermectin is above 16 nanograms per milliliter, and we can achieve that during 5 to 6 days, but no more. So we follow the schemes that we have now for control. I think the impact is expected to be very low. So we have to find a way probably for the people to have ivermectin higher than at high levels for a longer time. And this is, I think, the main challenge.
My name is Jörg from the Swiss Tropical and Public Health Institute. Jose, excellent presentation and very nice results. You, of course, also expect my questions. How do you see the comparison now of this potential new fixed dose, albendazole ivermectin, versus emodepside? You've seen the early results with a single dose, specifically against trichoris, even higher efficacy.
Yeah, we saw that there was, compared to albendazole, I mean, there was 80 in a dose escalation study published in the New England, very nice. A high efficacy, 86%. I don't know, I mean, my emodepside has been tested for onco at the moment, and now for STH also. One thing that I think albendazole and ivermectin has is that we are trying to establish this strategy not only for STHs, but I think it's easy to provide an effect or to have an impact in other diseases, not only in malaria, as Humberto was saying, but also on scabies, ectoparasites, LF, and other. So I think may have an impact. Beyond what we can do in STH, that's, I think, one point that I think is supporting still, if emodepside is very good, the use of ivermectin and albendazole, but I would go for a trial comparing both drugs, and that would be very nice to do and see what's happening in the same control scenario.
Before we go to the next question here, just to add, there are other activities of ivermectin, for example, for loa-loa, so I have now to raise the flag for loa-loa. You can't give this drug combination in most of Central Africa and important parts of West Africa. So what is your strategy for this?
I think it's the same that they have been doing for the last decades. So we know that there are, I think, 8 countries in Sub-Saharan Africa that have loa-loa, and there's a lot of strategies to do test and treat. I mean, test and not treat. Yes. Test and not treat, sorry. So we would probably not invent the wheel and just try to follow the path they have been doing. We know that ivermectin has this limitation, of course. True.
Thank you very much. Ayola Kimadeinka from Gabon. And I will start from your test, treat or test, not treat. Because the same apply for albendazole, which has also some effect on loa-loa. The risk maybe not at the same scale, but there's some also risk by using albendazole in a loa-loa endemic area. Just to assist my dear colleague and friend Michael here, then we can discuss that later on. My question for you here regarding your work, very well, thank you very much. I'm very pleased to see this kind of a work presented here, because it's very rare that people reported on air soil toxin helmet clinical trial, which I'm doing constantly in Gabon. For instance, I'm surprised that you don't have any single ascaris. Is it done in purpose, or just you remove that data?
We removed. No. It's that was a constant question on the evaluation from EDCTP and from EMA. But as you saw in the meta-analysis, the efficacy for albendazole for ascaris is already 96%. So we don't expect a lot of increase in the efficacy. So when you calculate the sample size for looking at this difference, you get crazy. So we decided that there's no clinical benefit for albendazole in the co-formulation, but still it will be treated. So we decided to leave it as an exploratory endpoint, and of course we didn't see differences between the study arms.
Yeah, thank you. I mean, it will be very good to show it. Even if it's 100%, we will be happy to know that,
to see that everything is fine.
albendazole one dose is still effective. And the next question I have, it's regarding that you have a good efficacy using one dose.
Akim, your presentation.
Well, it's the moment for singing.
So, okay, yeah. The question I have is that I'm very happy, I would say, to see that you have very good efficacy with albendazole against spondyloiditis, which is not the appropriate treatment. How come?
I have the same question. So basically, we don't know, because the efficacy of albendazole against strongyloides is expected to be around 30 or 40%. There's a problem when evaluating treatment efficacy for strongyloides. We have done lots of studies on the efficacy, and Lisette is here to support my speech in case she wants to. In non-endemic countries, the usefulness of serology 6 months after to evaluate cure. But of course, microscopy has a limited sensitivity, and you have the risk of overestimating the efficacy of the drug. And this is what may have happened here. So
why
probably
not use the PCR. This is more
we
convenient.
did, and we don't have, and apologize because we don't have the results yet ready to show. But we do have the. We did the PCR, and we are waiting for them. Yeah, but I think it's a problem of the way we assessed the outcome. That's my understanding, but it is an hypothesis, and Lisette is saying yes.
Thank you, Akim, for the many very
Akim.
thoughtful questions.
I'm
Now
always
our
the
last
last
question.
one where they say only ask a very short question because there's Akim before. Thank you. Very interesting talk.
you.
My name is Jutta Reinhardt from Merck. We are part of the pediatric praziquantel consortium with very similar development. I have one short question. Who is going to pay for the product? How do you provide access? Short answer.
That's. Do we have time for answering this question? No. I mean, there's a pharmaceutical company called Liconsa that is linked to different foundations. So they are committed to decrease the price as much as possible. I think what won't probably happen, and I'm not in a position to say that because Liconsa should be here to say, what won't probably happen is to continue with the donation scheme that we have been having. I mean, and particularly for ivermectin, and you're from Merck, we don't have. Yeah. So we don't have a program for strongyloides itself. So that couldn't be covered by the donation. So I think it will have to be very affordable, low prices, but probably non-donated. I can get up to here. Yeah, for sure.
Coffee break, lunch break, more discussions. Thank you, Jose.
Thank you, Michelle. Thank you.
So it's my pleasure to welcome Olaf to the stage. Olaf Valverde from DNDi is going to talk to us about sleeping sickness now.
And the successful trial we did.
And the successful trial they did.
Yeah.
On a project that just ended. Thank you, Olaf.
And it was a special trial because sleeping sickness from the East African and South African part is a very rare disease. So we had to adapt, but I'm not going to advance more information. The first thing I have to say is that this project was almost completely funded by EDCTP with the support of the Fundação para a Ciência e Tecnologia of Portugal. First, regarding Rhodesian sleeping sickness or East African sleeping sickness, first I have to clarify that is the most, I'm not going to talk or to present the disease clinically, but is the most acute and severe form of sleeping sickness. And as it has been referred to before, is also targeted as elimination as a public health problem. It does not mean full elimination by 2030. You will see later why. is only targeted to as elimination as a public health problem. Up to now, and still now, until we hopefully get approval for this new drug, the only treatment available for advanced sleeping sickness in the East African part is with melarsoprol, which is a highly toxic drug. We started with our first meeting of the project was in Lisbon in the previous in two previous EDCTP forums, and we can present the results in this one, which is a couple of months after we completed our project. And in 2019, we started our trial that lasted for 3 years, including 1 year follow-up of the patients. So our immediate goal, hopefully by December this year, is to start the introduction of this new treatment into TB rhodesiense trypanosomiasis. But first, to make a clear difference between what is the most prevalent form of human African trypanosomiasis, which is caused by Trypanosoma brucei gambiense, you can see in the line here, you can see the geographical distinction between both forms. And also you can see the red dots, which are the places where cases of gambiense have been detected, and the blue dots where you can see the places where Trypanosoma rhodesiense has been detected. So it's not a disease that covers whole countries. It's placed focally, and it has a different ways of transmission from gambiense than rhodesiense. But going into our own project, it was not only the clinical trial. The work package 1 and important part of the work package 2 were dedicated, of course, to the clinical trial and to increase the diagnostic capacity, not only within the clinical trial teams, but also in the peripheral health centers of the clinical trial sites. But work package 3 was also very important to engage the local community in preparation for access to the new treatment, and to facilitate the extension of case detection, in the sense that not always the people living in those areas is aware that the disease still exists. So zooming a bit more in the map, we can find the two places where we decided to start the clinical trial. In Luala in Uganda, which was a place where a previous clinical trial had been done with melarsoprol, a short treatment instead of 35 days, only 10 days, just comparing melarsoprol, which was the reference drug, but still toxic. And in Rumpi, which is the area where endemicity was high in Rumpi in Malawi. So the classic study title is, of course, looking for efficacy and safety of the drug, Trypanosoma brucei rhodesiense. But the objective, and this is something that I will say a bit more, because the objective is to show, we are not looking for demonstration, we are looking to show that fexinidazole offers an alternative. So we are not looking to put up front the perfect result of the study, especially because, and you can see below, we could only recruit 45 patients realistically, and I am talking about 2 years time of inclusions for the patients. And of course, from those 45 patients that we could include, we had a minimum sample size, minimum evaluable sample size of 34. So it took 26 months to get all those patients. We started by the end of September 2019, and we completed the follow-up in October 2022. interestingly, what happened when we started, you can see the blue bars especially in November and December 2019. At the beginning, our trial was at the same time of an outbreak in Malawi. The blue bar is Malawi. But the outbreak more or less was completed by the month of February, where we had clearly passed above the expected recruitment line that you see in the dotted line. And then it started to become much more difficult. We got a very late approval of the clinical trial in Uganda with the interference of COVID pandemic. And you can see just in April and June 21 that we got our only 2 patients from Uganda. And those were all the patients that had been reported in the country. We had, after this desertic period between December and March 21, December 20 and March 21, we had to extend our search area for cases 300 kilometers away in both sites, which made it quite complex, quite difficult, and made us also spend more than what was expected. But we could gather some funds from other donors. So the study was, the inclusions were completed in November 21. As I said, the study was, the follow-up was completed in October 22, and we could complete the analysis and the project report, and we are preparing our publication as soon as possible in the next months. So 34, I remind you, is the sample size that was planned in order to get a significant difference with the benchmark limit that we had fixed at 8.5% mortality at the end of treatment. And this is what makes this study a bit special, in the sense that we were not looking only for the benefit of the product itself, but we were looking for the difference with the mortality that had been found in previous clinical trials during treatment time attributed to fexinidazole. So there were two main, there were several, of course, primary and secondary objectives, but there were two main objectives. One was survival at the end of the treatment period, which was the period where melarsoprol could do its encephalopathy known adverse effect, but also the follow-up after 12 months to guarantee that the patient remains secure and there were no or little relapses. 32 patients were male, 12 female, and most of them adults, but still we had a big proportion of children below 18 years of age. We had only one screening failure, and 44 patients completed. And we detected one relapse at week 9 on all patients, and this will come later, you will see in our secondary objective. One person died on the 6th day of treatment, but it was thoroughly discussed, this case, and it was considered by the investigator, by ourselves, but especially by the Data Safety Monitoring Board as non-related with trypanosomiasis or the drug itself. And we could include, the inclusion criteria were wide open, and we could include one pregnant woman that came by the end, and who had been already detected with trypanosomiasis at the beginning of the year, and had been treated and failed with melarsoprol. But what I can also say is that we have visited this woman recently, and her child is thriving well. And we were open to recruit breastfeeding women, but we didn't find any. So these are the efficacy results. The primary objective, I remind you, was to show that the fatality rate at the end of hospitalization in patients with advanced trypanosomiasis. Advanced trypanosomiasis means that the central nervous system is already affected, was smaller than the unacceptable rate of 8.5%. This was the benchmark that was fixed according to the results of the previous trial and historical results that we found around. And it was achieved. You can see that although we had 0 cases, the confidence interval was estimated, having 0 cases, that would be below this 8.5%, and that was what helped us to determine the sample size. But the secondary objective, to show that the proven failure rate at 12 months follow-up in patients with advanced stage 2 was below 12%, was not achieved. We had 1 case only, but you can see the wide confidence interval in stage 2 between 0.15, 12, 85. So this secondary objective was not achieved, although for the total population, yes, it was. And something that we use in the trypanosomiasis, in the African trypanosomiasis world to measure the inflammation or the affect, the infection of the central nervous system is the number of white blood cells detected in the cerebrospinal fluid per microliter. And in this case, the average at screening was 62. By the end of treatment, it had already reduced to less than 20. And then by week 9, month 6, and month 12 was much lower. The limit we consider on the affectation of the central nervous system is about 5 cells, which was clearly achieved at month 12. And here is the efficacy. I brought you the whole list of the adverse events that were detected. And on the right side, you can see those that were possibly attributable to the treatment, which were only 6. You can see that the most present effect is gastrointestinal disorder, which was already known in the previous trials for fexinidazole for trypanosoma gambiense that we have done, completed, and the drug is in use. And of course, we had much more patients in the gambiense area. And vomiting, gastritis, and then electrocardiogram abnormalities that were already known, especially small QT prolongation that does not bring an increased risk towards the heart. Then you can see that other adverse events reported were very low in general. And during the follow-up period, we reported only the serious adverse events, and you can see that from the serious adverse events, we had 3: acute kidney injury during the treatment period, which was the patient who died in the hospital, a pneumonia, and a urinary tract infection. The urinary tract infection was in the pregnant woman, which were after the treatment and did well afterwards. And then I can. This is what I have for the clinical trial. I will present more deeply the results in the Congress, in the European Congress in Utrecht, that is coming up in 2 weeks. But I wanted also to mention something that I think it was a very important part of the project outside the clinical trial. First, it was the training on diagnosis, because the disease being so rare, it's difficult to keep up with the technicality needed to do the case detection. And especially, and something that I heard during this forum, is that I heard it was a 19th century technique to do microscopy for malaria, but it's not a 19th century technique to do microscopy for rhodesiense trypanosomiasis. And the problem is that many of the cases were diagnosed in patients with malaria, or where malaria was looked at, and then the trypanosome could be seen. So this is becoming a problem to us because there are not rapid diagnostic tests, and we try to find out the best alternative solution to detect the treatment. Anyway, there was the training for lab technicians, the training for nurses, the training for prescribers, and we extended from Malawi into a new target area in Kota Kota. And in Uganda, there was a generalized training on clinical and laboratory staff. And we did 2 ethnographic studies with communities in both countries. There are four papers that are prepared for publications, and from those studies, a discussion was done with the national responsible, and communication materials were prepared and published and distributed. This is one example of a communication material that we thought it was necessary or very useful for Malawi. This is in Chichewa, the text of where you can see that the transmission between humans is possible. And this is the very main way of transmission of Gambiense trypanosoma. But then the transmission of Rhodesiense trypanosoma is between animals and humans, because it is characterized as a zoonosis. And you can have, and this is the case mainly in Malawi, between wild animals and humans, but also, and this was the case in Uganda, that's one of the reasons why it is very low, because they did a very good campaign, between domestic animals and humans. Also in Uganda, this is the previous one was communication material from Malawi. Those are communication materials from Uganda. And one of the things that were detected in the clinical trials was the risk of discrimination. And the intention was to clarify that it's not contagious, there is no risk in helping or caring for sleeping sickness patients. And the other one is the quick progression, especially in Rhodesiense, and the second is prepared to alert on this. And in conclusions and conclusion of this, and talking about what should happen in the near future, we found that this is a really promising alternative to the existing treatments. The primary objective was achieved. Pharmacokinetics confirmed the profile that we already knew deeper with Gambiense trypanosomiasis, and allow us to refine a full pharmacokinetic model, which I have not introduced here. And we did also qPCR tests, both for DNA and RNA, and the RNA was transformed into cDNA. We found one relapse, and most probably this relapse was the same strain, so it was really a true relapse. Regarding what we want to proceed, we are now in the middle of the process. We submitted the dossier together with our industrial partner Sanofi. We submitted the dossier to the European Medicines Agency in May. We expect their final answer mid-December this year. And just after we get, hopefully, the positive opinion from the EMA, we are working together with WHO to prepare the adaptation of the new treatment guidelines, the inclusion of fexinidazole, the registration in the two countries where it has been registered already for trypanosoma gambiense, Uganda and Democratic Republic of the Congo. And the idea is to extend the use through a ministerial approval in the other endemic countries. This should happen at the beginning of next year, in the first half of next year. We count on a program of drug donation from Sanofi to WHO or to the governments via the WHO, existing since 2001. And the next steps are, of course, continue with the health staff training on the treatment with fexinidazole. Continue pharmacovigilance activities. As you can imagine, that with this small sample size, we would need at least more safety data on trypanosoma rhodesiense effect, and of course to launch or to continue with the community awareness activities. So this is what we wish for the future. I want to thank especially the real heroes of this story, which are the investigators and the teams of the investigators in both countries, but especially the last one, Dr. Westin Nirenda, which was the one who had to deal with a lot of difficulties, including not only the COVID, but also a cholera epidemic in Malawi, and that help us really complete this trial with 95% of all patients recruited there. And of course, thanking the participating patients. My final slide is a thank slide for all the partners that we have in our trypanosomiasis project, including, of course, for this particular study, for this particular project, EDCTP and the Fundação para a Ciência e a Tecnologia. Thank you very much.
So Olaf,
Yes.
Olaf, I'm sorry, there's no time for questions now, because we want to give due time for Charlie to give his final presentation, but you are at the booth of DNDi.
Yes.
In case people have any questions for you, or you find him after the session. So thanks again, Olaf, and we move forward with the final presentation.
Yes, Olaf. Olaf already mentioned that we need new diagnostics for sleeping sickness because of, well, the fading out of the microscopy for malaria, and our final talk will be about this, and we are very happy that Dr. Charlie Compaoré has made it in an adventurous travel here to come to Paris, so very good to see you here.
Thank you very much. I'm Charlie Compaoré from Burkina Faso. I'm very honored to be here today, and I would like to express my gratitude for the opportunity to share our studies to this estimated audience. And it's about molecular diagnosis test specificities and their contribution for ART post-elimination monitoring in Burkina Faso and in Côte d'Ivoire. Human African trypanosomiasis is known also as sleeping sickness. It's a life-threatening parasitic infection transmitted by tsetse fly in sub-Saharan Africa. And sleeping sickness is caused by two subspecies of Trypanosoma brucei. First, Trypanosoma brucei gambiense and Trypanosoma brucei rhodesiense. This disease is also, although it's caused devastating epidemic in the past, right now are now fallen into the historical level thanks to sustained and coordinated effort, both medical control and vector control. So thanks to this effort, the number of reported cases have progressively decreased until the number fell below 10,000 cases in 2019 for the first time in 50 years. Against this backdrop, in 2011, WHO have included ART in its roadmap, which aimed to eliminate this disease in 2020 as a public health problem. The first goal indicator has been amply achieved with 663 cases reported by 2020, well below the target, which was 2,000 cases. Several countries then have eliminated these diseases as a public health problem, and who has set another target by 2030, that is stop the transmission of the diseases by 2030. In this context, the diagnosis performance and the cost of diagnosis algorithm for early detection of Trypanosoma brucei gambiense heart reemergence remain to be assessed. So already WHO has a target for product profile for further strategies against sleeping sickness. So the molecular tests we have evaluate must meet this target product profile if we have to use it in the future against sleeping sickness. And that is what we need, and that is what we are looking for. Sensitivity and specificity must fit this characteristic. So in the context of, in the low prevalence context of our countries, we need tools and strategies which are adapted. So the current study aims to assess the specificity of molecular tests. And secondly, molecular tests on dry blood spots, okay? But before that, we did two studies. So the first was a medical survey in Burkina Faso and Côte d'Ivoire. And the second one, we tested the sensitivity of the molecular test. Here you have the paper we published after the medical survey in Burkina Faso, in southwest Burkina Faso, and using free RDDs in the field. Here you have the paper about the medical survey in Côte d'Ivoire, using also these free RDDs you see in the previous slide. So we perform molecular tests to assess the specificity in a total of 1,000 samples, which were selected randomly from a wide database, around 9,000 samples from both countries. And for each country here, we selected 500 samples and 500 samples for the test, the molecular test. So DNA extraction following the process according each dry blood spot we use, Matovi for the lamp and another one for Wortmann 4, including the use of free spot with 6 mm for Wortmann 4 and another for Wortmann male 1. And then we perform M18S. M18S is a primer who target the group trypanosome, and for the lamp also it target the group trypanosome, and we use TGSGP, which is a primer which target the Trypanosoma brucei gambiense. So what did we find as a result? The study population had a mean age around 25 years old, and for female we have 52%, and for the male we have 47%. The result for each RDD we use on the field were as follow: 8.1 and 8.1 and 0.4 for zero strip and 5.24 at SW line. Here you can see in the picture I'm doing RDDs for population in southwest Burkina Faso. For the result of molecular test, we have for M18 specificity 99%, and for serocassette we have for TGSGP we have 99%, and for LAMP we find out 100% because all the samples were negative for the LAMP. For the molecular test, M18 and TGSGP both show a good sensitivity. But according to our previous studies, the sensitivity were very low. So in our country, countries like Burkina Faso and Côte d'Ivoire, we need to verify the elimination of the disease. So we need a high-through test, which we can use for test at-risk population comprehensive coverage. Okay, that is why high-through method for population level cross-cutting surveillance of Trypanosoma brucei gambiense is a good product profile for these countries with the epidemiological context we know. But these molecular tests, both of them are time-consuming also. So this is another disadvantage of those tests. So it's not high throughput test as we need it. These countries, then we need another molecular test that will match very well with the target product profile. Because in one side we have a good specificity, but in another side we don't have a good sensitivity, and it is not high throughput test. There is actually some research under the way that detect RNA, namely trypanosome RT-PCR multiplex, which can detect DNA and also RNA. We have secondly Sherlock hat based on Cas13 diagnosis. And also we have ongoing study on the cost calculation of different algorithm diagnosis. As we know, we need also to find the less expensive algorithm in order to implement it in health facilities and in our fight program against sleeping sickness. This means that even if fight against sleeping sickness has made a lot of progress these 2 decades, past decades, there's still a lot to do up to date. And I would like to finish my presentation by thanking all the people, the organization, for their commitment to the achievement of this work. Especially, I would like to thank EDCTP for funding our project Detect Art, in which I did my thesis just 1 year ago. So thank you. And also, I would like to thank EDCTP especially for giving me a scholarship to be here. And in EDCTP, I would like to name some person like Michel Helsinki. Thank you for answering my 100 or 1,000 mail and question, and manage that so that I can be here today. So thank you for your attention, and sorry for my English. I'm French speaker. I try my best. I'm sorry for English speaker. I'm available to answer your question.
Thank you, Charlie, for this very, very wonderful last presentation. We have run a little bit out of time, so we invite everyone who has a question for Charlie to please come to the front just after we finish our session. I'm sure Charlie will be around for the next couple of minutes. I thank all of you for having had this interest, these lively discussions, for having been here, and I wish all of you a good continuation of this EDCTP forum.
Thank you. Enjoy lunch. Oh, and if you're attending Meet the Expert session, go find your expert now.